Hey, it's Paul Logan. Part 2 of cardiovascular drugs this week. We're going to start talking about antiarrhythmics. So antiarrhythmics are drugs that help keep the heart in a normal rhythm or within a normal range of rhythms, right? So normal conduction happens this way. The impulse starts in the SA node or the sinoatrial node, or sometimes we just call it the sinus node. And that's where the impulse begins. That's the pacemaker cells of the heart. They are responsible for picking the heart rate. 68 beats per minute, 92 beats per minute, whatever. All right? So the SA node starts that, and then that causes atrial depolarization, right? Where the atria depolarize, which we hope then, although we don't see it on the EKG, we hope that that depolarization is accompanied by contraction of the atria, which squeezes the blood down into the ventricles. Why squeeze the blood into the ventricles? Well, because that's where the blood's going to go to get out to the rest of the body. Now, when the ventricles contract, then the blood goes out to either to the lungs if it's leaving the right ventricle, or to the whole body if it's leaving the left ventricle. So again, the SA node, atrial depolarization starts here, and it comes down these pathways, and then it takes a break in the AV node. All right. That little coffee break that we see is the PR interval. Remember that. We're going to come back to it. Then, after it takes a little break, which allows for ventricular filling, now that impulse is going to go down the bundle of His and split into the right bundle and the left bundle. Okay? When we see it on the EKG, it looks like this. We see a P wave representing atrial depolarization. This is coming from the SA node, right? And then it takes time for that blood to get into the ventricles. So we have this long period of time here called the PR interval, and that is the amount of time that filling of the ventricle can take place. After the PR interval then comes the QRS complex. That's the ventricular depolarization. And again, we hope, although we don't see it on the EKG, we hope that there's contraction at the same time, right? That the ventricle will contract and pump the blood out. Again, we don't see that. We just see the electrical activity going on. So the QRS complex corresponds to ventricular contraction, even though we don't see the contraction happening. And then there's this thing called the T wave, and the T wave represents ventricular repolarization, or recharging, getting ready for the next time. Okay? When we're talking about antiarrhythmic drugs, we have to take into account this period of time, from the beginning of the QRS complex to the end of the T wave. That period of time is called the QT interval, and that is important when we're giving certain drugs, because one of the ways the drugs work as antiarrhythmics is to prolong that period of time. But if we prolong it too much, that's not a good thing. Okay? So normal sinus rhythm looks like this. We have a P wave for every QRS complex. P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. See, I told you. So that's part of it. The second part of it is the heart rate has to be between 60 and 100 beats per minute. I can look at this and tell you that the heart rate is, watch this, this is kind of cool. So I'm starting on a tall, or on a thick blue line in this case, and I'm going to count the next blue line and the next blue line, the next blue line, until I get to the next QRS complex. And I'm going to repeat these numbers as I do it. So I'm starting here, go to the next big blue line, and say 300. If the next QRS complex was here, the heart rate would be 300, but it's not. So I'm going to say 300, then I'm going to go to the next one, 150, next one, 100, next one, 75, and now here's that QRS complex. So the heart rate's a little slower than 75, right? So let's call it 70. If this wasn't here, then I would keep going, and I would count down here, which is 60, and I would count here, which is 50. And then we don't go any further than that, because if the heart rate's slower than 50, then you may have a problem. All right. So again, this little cheater method for a regular rhythm, you can look at this and count from a QRS on a thick blue line. Count the next thick blue line, say 300, 150, 100, 75. Okay, there's the QRS, so it's a little less than a heart rate of 75. Got it? Pretty cool trick. So let's do that trick here. Let's find one of these that goes, so we see that they're about the same distance apart, so it's a regular rhythm. But here's a QRS that's on a thick blue line-ish, and now I'm going to start counting. 300, 150. So this heart rate is just a little bit less than 150. If it was over here, it would be a little faster than 150, right? But here it's a little less than 150. So what, 140, okay? So this is sinus tachycardia. There's a P wave. Actually, the P wave is here. P wave is here. P wave is here. P wave is here. And a P wave for every QRS. Okay? When the heart rate's more than 100, and in this case, it's almost 150, right? And there's one P wave for every QRS, that's sinus tachycardia. We see this with nervousness, anxiety, fever, dehydration, deconditioning, all sorts of things. We also see PVCs, or premature ventricular complexes, because again, we don't see the ventricle contracting, right? We call it a PVC because we just guess that the ventricle's contracting, but we don't actually see it contracting. We're just taking our word for, or taking the EKG's word for it that the ventricle's contracting. So really a better term here is PVC, premature ventricular complex, right? So two things about PVCs. One, they come early. So here we see this nice pattern that's established here, right? We go about 3 big boxes, 3 big boxes, 3 big boxes, and now 2 big boxes, not even 2 big boxes. And we have this early beat. So it's an early beat and it's wide and really goofy looking. That's usually a PVC. Here we see a rhythm that is irregularly irregular, right? There's no pattern to this at all. Here it goes blip, 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 blip. See? That irregular rhythm, irregularly irregular, and there's no discernible P waves. There's all this junk here, but you don't even need to see the junk. You just don't see P waves. That's the diagnosis for atrial fibrillation. Irregularly irregular rhythm, no discernible P waves. That is the way to diagnose atrial fib. I don't want to hear about irregular baseline or any of this other nonsense. Irregularly irregular rhythm, no discernible P waves. Okay? By the way, what's a regularly irregular rhythm? Well, that would be like this. It would be blip, 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 right? It's that same pattern over and over again. There's regularity to it, but it's irregular because there's an early beat in there. Okay? Now there's this thing called PSVT, or paroxysmal supraventricular tachycardia. This is where the heart rate's more than 150. We kind of made that number up, right? Could be 300, could be 160, but it's more than 150. The tachycardia originates above the ventricles, and we know that because the complex is narrow, right? Whenever you see a narrow complex tachycardia, that's always SVT. Now, sometimes SVT can be wide complex, but that we'll talk about when you're senior in 405B, actually 405A, but whatever. For our purposes, if it's faster than 150 and narrow complex, we're going to call it PSVT. If it's wide complex, right? Wide complex, and what does that mean? Well, that means that from the beginning of this to the end of this is more than 3 little boxes. So here we count 1, 2, 3, right? So this is more than 3 little boxes wide. Wide complex, This is life-threatening because it can degenerate and turn into ventricular fibrillation, which looks like this. Now, this is a special case of ventricular fibrillation, and Americans call it torsades, but the French would call it, however you say this, torsade de points, or whatever. I don't know how you say it because I took Spanish, which I don't know either, but I know that my French pronunciation of torsade de points is not very good. Anyway, we're going to call it torsades because we're just Americans, and that's how we say it. So this is a particular lethal ventricular arrhythmia. We see this happen with antiarrhythmic drugs. It can also be associated with something called long QT syndrome, but the cool thing about it is it gets better with magnesium. Now, how do you see torsade de point? Well, what this means is twisting around the points. And it looks like this gets tall, and then it looks like it's going on its side when it gets real small, and then it gets big again, and then it gets real small. It looks like it's twisting, right? Twisting around a point. So that's why we call it torsades. Again, when you see torsades, think two things. Think magnesium and think antiarrhythmic drug, right? The antiarrhythmic drug caused it. The magnesium is going to fix it. So why do we, or how do we think about myocardial depolarization? Well, remember when you were in physiology class and you learned about the action potential and you thought, where am I ever going to need this? Well, this is it. This is where you need to know it. All right. So remember that the first phase of the action potential, which produces the heartbeat, in this case, the QRS complex, is going to be produced by phase 0, where sodium influx occurs. Sodium rushes into the cell because it's normally an extracellular ion, and it rushes into the cell, and then that forces potassium and chloride out of the cell during phase 1, and then phase 2 is where calcium comes in, and then phase 3 is where potassium goes back out, right? And then potassium goes back in phase 4. All right. Now, this is the way that the action potential looks in the ventricle. But remember we talked about the SA node having different rates and how it can speed up or slow down the heartbeat as the pacemaker of the heart? Well, that's because of this slant here. This phase 4 takes some time to get back up to phase 0 where it has an all or none response. As opposed to this in the ventricles where it goes along nice and flat, and then it's told contract and it contracts and this happens, right? This is the general ventricular action potential. But the reason that the atria work the way that they do, or the SA node works the way that it does, is because it has a different shaped action potential. And that means that it can slow down the heart rate where this is a much flatter course, or it can speed up the heart rate where this is a steeper curve. Okay. And here you can see those things reflected again. So this is the ventricle, and this tells us that that class 1 antiarrhythmics are typically affecting the ventricles, but not always. And also class 3 has a big effect on the ventricles. But look at this. This really affects the SA node and the AV node, and that's why the action potential looks different. All right, so that's sort of advanced stuff. You don't really need to understand that in order to know about this classification system for antiarrhythmic drugs. The class 1 drugs are sodium channel blockers. So we have that group divided into 3 parts: the 1As, the 1Bs, and the 1Cs. The one that we're going to focus on is the fast sodium channel blocker, lidocaine. Lidocaine is a medicine that calms down ventricular arrhythmias, and we're going to talk about it in a little bit. Beta blockers, remember my favorite drug, right? Cuddly drugs, very fun to use. They have just wonderful characteristics. They decrease your heart rate, they decrease your blood pressure, they relax your heart a little bit, all good things, right? So these beta blockers also have the ability to decrease automaticity, to slow the SA node, okay? Class 3 antiarrhythmics are the potassium channel blockers, and these prolong the refractory period. What does that mean? That means that this will widen your QRS complex and therefore widen the QT interval, and that's the thing that we have to monitor on the EKG for class 3 antiarrhythmics. We also classify calcium channel blockers as class 4 antiarrhythmics, but only the non-dihydropyridines, right? Remember the dihydropyridines, nifedipine, amlodipine, the other pines, those drugs don't affect the heart rate. They don't affect the heart rate. So we're not going to count them in our antiarrhythmic drug fan pool here. Okay? Only Diltiazem and Verapamil count. And then we have so-called class 5. This is made up. There's really no class 5, but it's just for the other ones that don't really fit anywhere else. DIG. Did you know that DIG can slow the AV node? It can slow conduction through the AV node. That's why it's an antiarrhythmic. Adenosine is kind of a cool drug that you'll learn about today. And then MAG, as we talked about briefly before. So what are the benefits of antiarrhythmics? Well, they're very cool because they can restore a normal heart rhythm. If your heart freaks out and is going 1,000,000 miles an hour and you're in ventricular tachycardia or SVT or whatever, then we can give you an antiarrhythmic and put you back into rhythm. It can prevent you from passing out, and it can prevent deadly ventricular arrhythmias. It's perfect, right? Like, what could go wrong? Well, we thought, I wasn't actually involved in this decision, just to be clear, but in 1991, these investigators published a trial called CAST. Well, what they did was they took a whole bunch of people who had had a big heart attack, and they randomized them either to get no drug or to get an antiarrhythmic drug. Remember, they all had PVCs. They all had a heart attack. And we randomized them to see if we could get rid of their PVCs, their extra ventricular heartbeats. Okay? So they all had a heart attack. They all had PVCs. They got put into either the placebo group or they got put into the antiarrhythmic group. And the antiarrhythmic in this case, there were two choices, either enconide or flecainide. By the way, they don't make enconide anymore, so that should probably tell you how this trial turned out. Anyway, we gave all these patients these antiarrhythmics, and we thought, this is great. We're saving so many lives because these people aren't going to have arrhythmias. Well, guess what? They did. They had arrhythmias. Why did they have arrhythmias? Well, it turned out the cure was worse than the disease. When you have an abnormal heart muscle, you can't be on certain antiarrhythmics, like we learned enconide and flecainide. We certainly know this now, but when I first started practicing, this was brand new knowledge. We did not know how dangerous these drugs were. Now we do. Now we do. But we learned it the hard way because we assassinated all these participants in this trial who got randomized to flecainide or enconide. The ones in the placebo group actually did better. So this is why good ideas in medicine always, always, always have to be tested. We can't just say, you know what, I'm sure it's a good idea for you to be on aspirin because that's going to lessen your chance of a heart attack, we think. Well, that's not good enough. Just like it wasn't good enough for these people for us to say, hey, you've had a heart attack, you have these extra heartbeats, we think you're likely to die from a sudden arrhythmia, so let us give you this antiarrhythmic that will prevent those extra heartbeats and make them go away. Well, it made those extra heartbeats go away, but it put them at risk for sudden cardiac death because instead of just benign PVCs. Now they were having ventricular arrhythmias and dying. So these are not cuddly drugs, all right? Antiarrhythmics are not cuddly drugs, at least not the class 1 or the class 3 antiarrhythmics. Class 2, beta blockers, of course, they're cuddly. Class 4, yeah, they're pretty cuddly too, right? Calcium channel blockers, it's hard to hurt somebody with them. Well, let's talk about the 1B agents. Lidocaine is one of really 2 drugs in the 1B class, but I just want you to use this to sort of learn about the class 1 antiarrhythmics. So lidocaine is the one that we're going to pick. It is indicated for ventricular dysrhythmias. You give 1 to 1.5 milligrams per kilogram IV push, and then you can repeat once after 5 minutes, or you can use an IV drip. We don't reach for this drug first in a code anymore. We used to, and you still can, but we like another drug better. But this one we still use. It is contraindicated in heart block and WPW. We're going to talk about WPW in a little bit, but it's Wolff-Parkinson-White syndrome. We just don't want to give it in any condition where either the AV node is broken, or in WPW, the problem is that there is a bypass tract that goes around the AV node. So we want to avoid the drug in either one of those situations. The most common thing that we see acutely with lidocaine is that it can cause hypotension. Sometimes it can cause heart block and bradycardia, and sometimes it can cause proarrhythmia, which means produce arrhythmias. But in the long term, the real problem with lidocaine is CNS toxicity. So I always want you to think of the brain when you think about lidocaine, and also think about Kyle, right? Because these are not cuddly drugs. One reason they're not cuddly is that it can induce an arrhythmia. Another reason is that it can mess with your brain, right? It can make you confused and twitch and convulse and all sorts of badness. Anytime that we have somebody on this drug, we want to continuously monitor their heart, monitor their electrolytes, and look for indications of CNS toxicity. Okay? Metoprolol, again, are beta blocker, class 2 antiarrhythmics. They're very cuddly drugs, just like the unicorn doll. These are indicated for tachyarrhythmias. We already talked about for hypertension and for heart failure. But this week we're talking about them as being necessary or useful for tachyarrhythmias. That means fast arrhythmias. So ventricular arrhythmias, maybe, but not so much. Mostly the supraventricular kind, right? The atrial arrhythmias. We talked about beta blockers, so you know about those things. All right. Now is a class 3 antiarrhythmic. Now look at this. It has Kyle and it has the unicorn. Well, why is that? The reason is that we love amiodarone in the short term. It's safe. Unlike flecainide and encainide that were used in CAST, amiodarone is safe to use in people who have bad left ventricular heart muscle function, right? So it's okay to use this drug in those patients, but only in the short term is it really safe and cuddly. We like it. We can't hurt people with it in the short term, so we really like amiodarone. The problem is that the more it sticks around, the more you use it, the longer period of time that you give it, over months and years, it can build up in the tissues, and that means that it can cause problems there. It can also do things like increase concentrations of warfarin and DIG. And why does it do that? I'll give you a hint. It has to do with protein binding, We're going to talk about that. Well, actually, it's a separate lecture. You should watch that about the anticoagulants and antiplatelet agents. All right, so the other things that we don't like about amiodarone: liver toxicity, can make you hypothyroid. It can make you hyperthyroid, which is weird. Like, why would it be able to do both? I don't know, but it can. Pulmonary toxicity can make you have corneal deposits in your corneas, can make your skin turn blue. Yes, I said it can make your skin turn blue, and I'm going to show you a picture of it right here. This is amiodarone skin discoloration. You can see this bluish discoloration here. They publish this in the New England Journal every 10 or 20 years or so. There's a more recent picture, but this is one from ages ago when I snagged it. DIG we talked about before, so you already know the slide. You've already learned the drug. Now we get to the class 4 agents. These are agents like Diltiazem or Verapamil, right? We're going to pick Diltiazem because we use it much more commonly than we use Verapamil anymore. We use this for hypertension, as we talked about, but also for tachyarrhythmias, for fast heartbeats again, usually narrow complex ones. It's a calcium channel blocker, but it's a non-dihydropyridine, which means that it has an effect on the AV node and it has an effect on the SA node. Okay? We don't want to give this in heart block or in bradycardia. It can cause hypotension, which sometimes limits its use. We don't want to use it in heart failure because it just weakens the heart muscle without really doing anything beneficial for it, like beta blockers do. It just weakens it. Also can cause constipation. But the big thing is we don't want to use Diltiazem in WPW. What is WPW? Well, WPW is this weird arrhythmia where the impulse starts up here, comes down through these mechanisms, and then takes a break in the AV node, right? That's the normal pathway. Well, what can happen with this is this accessory pathway happens. This accessory pathway is the term I said there. This accessory pathway is a connection between the atria and the ventricles. Normally, that's the AV node's job, right? Well, this is extra tissue that lives up here and is a direct connection between the atria and the ventricles. Doesn't go through the AV node. And as a result, we can really get into trouble. And the trouble that we can get into is pictured here. This is circus movement tachycardia, where it just goes in a big circle. It goes down the AV node, and then it comes back up through the accessory pathway and back around again. And this is a reentrant circuit. The problem with giving a calcium channel blocker here is that it will not block this pathway. So it actually accelerates the impulses going through this pathway, and they can go through in the wrong way. If they come down from the atria, let's say you have atrial fibrillation up here, which is about 600 times per minute that you get an impulse in the atria during atrial fibrillation. If you have that coming down directly touching the ventricles, we call that not atrial fibrillation, but now we call it ventricular fibrillation or sudden cardiac death. So if you give a calcium channel blocker, you block this normal pathway, and now you accelerate conduction through this accessory pathway, and you could kill the patient. Probably not a good idea. This is what it looks like on an EKG. This is a posterolateral pathway. You can see this little thing called the delta wave. You can see how it sort of slurs upward, shortens that PR interval, slurs upward in this lead and in this lead. All right. So this is a posterolateral pathway. You don't have to know this, but it's kind of cool. You agree, right? So this is a fun drug. The deal with adenosine, maybe you've seen it given in the emergency room. It's very cool. The way it works is we give it and it totally blocks the AV node, completely stops all conduction through the AV node for a couple of seconds. Then it gets metabolized just like that, and you go back to normal again. But it's long enough to stop a arrhythmia circuit that goes through the AV node. And that's exactly what happened here. So here we have this SVT. It's going boop, 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 boop. We give the adenosine here, and now it's totally stops the conduction through the AV node. And then a normal heartbeat starts up here. Here's a PVC. Then it waits for another second or two. Then it starts the heartbeat normal again. It's a very cool drug. It's also very exciting to see given. It's kind of scary when the heart slows down and doesn't beat, but just know that the heart loves to beat. It loves to beat, and it does everything that it can to beat. So it's not going to just stop. Don't worry about that. Okay? It's important, listen to this, it's important when you have somebody who comes into the ER in rapid narrow complex tachycardia, or an SVT, it's important that you use a large bore IV in the antecubital fossa, in the elbow, right? And you put that large bore IV in there, and then you use a stopcock so that you can give the adenosine quickly, followed right away by rapid saline flush. So I don't mean give it rapidly, take the syringe off, put the flush on, and then do it. I mean, have a stopcock on there with both syringes filled, and then this is how fast you push the adenosine and the flush. You go adenosine flush. That's how fast. Just adenosine flush. Right in with the adenosine, flush it right in, and hold the arm up so that it doesn't get metabolized along the path to get to the AV node, right? That's how you use adenosine. Pretty cool. AFib is so annoying it gets its own section. I hate it so much. And there's three things really that you have to remember. Two things have to be done instantly when the patient comes into the hospital, right? We have to, or in the office or wherever, we have to control their heart rate, because usually AFib goes fast. And the second thing we have to do is anticoagulate the patient, right? Because if they're anticoagulated, they are less likely to have a stroke from a blood clot that can form in the atria. So we always want to put them on heparin or warfarin or something else that we can quickly anticoagulate them with. And then we want to rate control them. Usually their heart rate's 140, 150 or whatever. So we're going to give them some sort of drug that can slow their heart rate down. What do you think a good drug to do that would be? Yeah, beta blockers. Or Cardizem, a non-dihydropyridine calcium channel blocker. Later on, after we have had them anticoagulated for 3 weeks minimum, and after we do a study to make sure that they don't have any clot in their heart, then we can think about converting them to a normal rhythm. And we can also think about doing a procedure to keep it from happening again, called an ablation. Sometimes bad things happen though. So this is a patient who I took care of years ago. She was just lovely, and she had AFib for many years, and she came in one day because she had GI bleeding and terrible anemia, and there was no choice. We just had to stop the Coumadin. We did that, and we transfused her, and we discharged her home and hoped for the best. And then 2 weeks later, she came back with a giant stroke. And she died very shortly after. So, this is just one of those horrible diseases. We hate AFib, and we have to treat it as an aggressor. We have to make sure that we lessen the chances of it causing mischief. And AFib causes mischief by increasing the likelihood of stroke from clots forming in the heart. And it can also weaken the heart muscle if you let the heart rate go too fast for a long period of time. Now, I just want to spend a couple of minutes talking about dyslipidemia or hypercholesterolemia. I say dyslipidemia because maybe your cholesterol problem is high triglycerides and low HDL, but you have a normal LDL. Well, that's not hypercholesterolemia, right? That's dyslipidemia. So that's the way I say it. So just a couple of things. We used to think that HDL was the good cholesterol. Well, guess what? No matter what study we looked at where we tried to get the HDL elevated and see a beneficial effect on risk factors, we never saw it. We just never saw anything good happen by raising the HDL. So we used to think the HDL was protective and did reverse cholesterol transport and that it was good for you and all that. And while it does do reverse cholesterol transport, taking the cholesterol from the wall of the vessel back to the liver to get rid of, turns out that doesn't really help us. It doesn't help us. We just have never been able to find a study that makes it useful. So the study that definitely has shown the most traction is fixing the LDL cholesterol. And there are dozens of studies that show that when we lower the LDL cholesterol, we improve risk. This is definitely the bad cholesterol. And there's other ones too. There's VLDL, very low density lipoprotein. LDL is bad enough, low density lipoprotein. But VLDL is even worse. And then there's these other things like chylomicrons and things like that we're not going to worry about. But we do get concerned about triglycerides. Triglycerides are a function of carbohydrate metabolism, and we don't like triglycerides either. So when you eat, the triglycerides get picked up, as do chylomicrons, from your gut, taken to the liver. The liver distributes them in these LDL particles, and then it goes around the body and can eventually get laid down in this coronary artery or whatever artery, right? And that's what we don't like. We don't want that cholesterol setting up shop in the artery wall. So we have several different ways of treating cholesterol, and the standard thing for every single one is to fix their diet, right? Low saturated fat for high LDL, that's the right target. But for high triglycerides, which is also a problem, particularly in diabetics, and particularly in people who, how shall I say this, are built for comfort, not for speed, you know what I mean? So people who have that truncal obesity, the syndrome X kind of people, those are people who have in particular tend to have high triglycerides, and that puts them at risk as well. And for those people, alcohol avoidance and getting rid of sugar and simple carbohydrates is huge in reducing their, in fact, you can cure their hypertriglyceridemia just by getting them on the right diet. It's very powerful. But a low-fat diet does not treat high triglycerides. Make sense? So don't just think all these lipid problems are the same and then you can just prescribe a low-fat diet. Don't cut it. The drugs that we use for these patients are statins, and those are the ones that have the most evidence behind them, the best studies. So atorvastatin, simvastatin, rosuvastatin is the most, one of the more recent ones. There are others out there, Pravachol or Pravastatin, etc. But the statins, or the HMG coenzyme A reductase inhibitors, we just call them statins. Those are the only class of lipid drugs with outcomes data until this very exciting study came out with a particular fish oil brand that I think it came out about 2 years ago at the ACC convention when I was there. Other drugs that can reduce cholesterol are bile acid sequestrants. Niacin can reduce triglycerides. Fibrates can reduce triglycerides. But as I said, this fish oil study was really exciting. I'm trying to think of a big number. More than 90%, more than 95%, maybe 99% of all the patients with dyslipidemia who you encounter are going to be on a statin. Most of the people who are diabetic are going to be on a statin. Most of the people who have had a heart attack before are going to be on a statin. Most of the people with any chronic health problem that puts them at risk for coronary artery disease will be on a statin. Okay? And that could just be age, right? Your biggest risk factor is getting older. So once women are over 55 or men over 45, that's when you start to be at risk for coronary disease, or earlier even if you have bad family history. So the two things I want you to remember are liver and muscle, because these are the things that can be affected with statins. It can poison your liver, raises the AST, that's one of the liver enzymes. And it can also destroy muscle. Now, I think I've seen it once in my entire career where somebody gets rhabdomyolysis or muscle breakdown from a statin. Very, very rare, but not zero. So you gotta be on the lookout for that. Very commonly, patients complain of myalgias or these muscle aches. Well, that doesn't mean that their muscles are breaking down. We see myalgias constantly in probably 20% of the people on a statin. But that's different than the severe form of myalgias where there's actual muscle breakdown and their muscle enzymes are elevated. Okay? And that muscle enzyme that's elevated is the CK, or the creatine kinase. So whenever one of these medicines is started, we always monitor for muscle aches. We want to check the liver function periodically while they're on it. And then, of course, we're going to follow their cholesterol and make sure that their cholesterol goes down. And we usually give this drug in the evening. Recently, I don't know, 7 years ago, the first PCSK9 was released. Actually, it wasn't even that long ago, probably 5 years ago. The first PCSK9 inhibitor was released. This is a very specific thing on the cell receptor, or on the cell membrane, that is named the PCSK9 receptor. When we block this receptor, we knock the cholesterol down to almost nothing. In fact, in a study in primates, they found that those primates who were given a PCSK9 inhibitor did not develop coronary artery disease. How exciting is that? We may have a cure for coronary artery disease, and it may only cost $14,000 a year per person. Well, that's what the drug companies tried to charge us. We weren't hearing any of it, and there was a lot of uproar about it, and eventually they came to, right now, they're around $6,000 a year. Still a ridiculous amount of money. But for people who have really aggressive coronary disease, or who have failed on statins because they got muscle pain, or we can't get their cholesterol low enough, then these PCSK9 inhibitors are really big news. They are the most exciting drug that has hit the market ever since statins. Also, for the first time after 30 years of trying, we now have an omega-3 fatty acid that is proven to be beneficial. It decreases your chance of all-cause mortality from anything. So these are major adverse cardiac events is what this is. So MACE is major adverse cardiac events. And this includes heart attack, stroke, these major problems, heart failure, things that are really major things. Cardiovascular death, stroke, fatal or non-fatal, fatal or non-fatal MI. Those are major adverse cardiac events. So we reduce all three of these together. When we look at them together, we reduce them 26%. When we look just at MI, whether fatal or non-fatal, those come down 31%. Stroke, both fatal and non-fatal, come down 28%. And cardiovascular death comes down 20%. This is huge for fish oil, for crying out loud. Now, this is pharmaceutical grade fish oil, and we don't even call it fish oil. We call it icosapent ethyl. It's a long story, but it's one of the chemical derivatives from fish oil. Most importantly, if you look at this 5-year Kaplan-Meier survival curve, you can see that the patients who had Vascepa plus a statin had much fewer events at 5 years, and even fewer at 6 years.